The leader has muted your line. To unmute your line, press #6.
Good afternoon. This is Estella Balderas from the Midwest AIDS Training and Education Center. Welcome to today's call. Can someone please let me know if you can hear me? I believe you can, but just to make sure. Put it in the chat. And we'll be taking our questions via chat mostly. Oh, awesome. And we'll be taking our questions via chat. If there's time towards the end, we may open up the phone lines. This session is being recorded, and we will have the link of the recording available to you, and I will email that out to you later in the week. Also, at the end of the webinar, we'd ask if you could complete a real quick, brief survey. That's all we ask for. So here are our guests. We have today Jorge Sestu, Anita Irizarry, Ayla, and I cannot pronounce your last name, I'm so sorry, Kamustafa, David Kern, and Patrick Stonehouse.
Good morning, everyone. Thank you for joining us on today's webinar. Before we begin the presentation, I want to extend sincere thanks to the many partners across Chicagoland who provided input, feedback, criticism, and recommendations for improving the HIV services portfolio. We truly appreciate the opportunity to have heard from so many of you over the last 2 years. Just over the last month, my team has carefully reviewed the input we've received, including input from the Chicago Area HIV Integrated Services Council and the AIDS Foundation of Chicago's Service Providers Council. We set about the challenging task of synthesizing your feedback to identify common themes. And as you can imagine, your insights represented multiple perspectives and at times diverging points of view. While it wasn't an easy task, it was important for us to identify concerns and recommendations so we could reflect these in our final HIV services funding portfolio wherever possible. It's our sincere hope that what we'll share with you today conveys that we are listening to you and we have heard you. We hope that you can see we took your input very seriously and have responded accordingly. So again, thank you for your ongoing patience and commitment as we work together to create a system of HIV services for Chicagoland that we all can be proud of. We believe the portfolio that we're sharing today is forward-thinking and at the same time builds on the strong work that we've done together for many years in this jurisdiction. Given the amount of time we have, given the amount of information that we have to present and the time we have together, we may not be able to answer all of the questions during this webinar. Questions will be recorded and we'll provide responses as soon as we can. We will also be presenting the same information in a few upcoming in-person meetings. We'll be meeting with the Service Providers Council Medical Advisory Group on February 7th from 3:30 until 5:30. The Black Treatment AIDS Network meeting on February 13th from 2 to 4, and the Service Providers Council on March 1st at 9:30 a.m.
Go ahead.
For today's presentation, we'll be covering several areas. First, a brief review of Getting to Zero Illinois, a brief review of current Chicago data, a review of the CDPH and CAHEES planning process that brings us to today. Then we'll share information about the HIV services funding and a timeline for the remainder of 2018, the information we have at this point. So last year, the Illinois Getting to Zero framework was released, and the Zero asks us to focus on 0 new HIV infections and 0 people living with HIV who are not on treatment. The framework outlines 2 goals. The first, increase by 20 percentage points the number of people living with HIV who are virally suppressed, and the second, increase by 20 percentage points the number of people vulnerable to HIV infection who use pre-exposure prophylaxis. Modeling suggests that if we're successful, we could see fewer than 100 new cases of HIV by 2027. And for us, 100 is what we consider to be functional zero, or the point at which the epidemic can no longer sustain itself. So how do we get to the Getting to Zero goals? How do we achieve them? Well, first, folks have to understand their own healthcare needs. Second, folks have to know healthcare is accessible and know that healthcare is valuable to them. Folks have to desire to engage in healthcare. Folks have to seek healthcare, reach healthcare, and ultimately use healthcare. Another way to look at this is the common path to HIV medications, which is included in the Getting to Zero framework. And you see the first step is outreach, education, and marketing to folks so they know that services are available and valuable. The second step is HIV testing, so individuals know their HIV status. And regardless of that status, individuals need to be linked to healthcare, and when they're retained and engaged in healthcare so that they can be prescribed antiretrovirals for PrEP and HIV treatment. We also know that individuals face challenging life circumstances. So in addition to the healthcare services that they're provided, they must be provided essential support services that give them every opportunity to stay engaged, use ARVs, and successfully become virally suppressed or use PrEP. So current data, in 2016, the City of Chicago diagnosed 839 new HIV infections, which was the fewest since 1990. 80% of individuals were linked to care within 30 days, and more than 90% were linked to care within 1 year. But disproportionate burdens remain. In particular, populations of men, 20 to 29-year-olds, non-Hispanic blacks, and gay, bisexual, and other men who have sex with men. While this is positive news, we have a long way to go to get to the goal of functional zero, or only 100 new HIV diagnoses per year. We continue to face challenges keeping people in care and successfully using antiretrovirals for treatment. In 2016, only 60% of people living with HIV accessed care. Only 40% were in care consistently, and less than half were virally suppressed. Conservative estimates indicate that only about 10% of individuals eligible for PrEP are using it. So again, in order for us to get to zero, we must provide increased opportunities for people living with and vulnerable to HIV to receive health care. CDPH has been working for the past 25 months on the HIV services portfolio. So I'll walk through some of the milestones that we've gone through in those 2 years. First, CDPH, with guidance from the Chicago Area HIV Integrated Services Council, developed Centers of Excellence, the concept, to promote antiretroviral use toward viral suppression and PrEP. In November of 2016, CDPH released the Centers of Excellence summary document. After the release, we heard widespread feedback that folks in the community, providers and community members, wanted more time to provide input. So honoring community feedback, CDPH and CAHISC agreed to continue conversations about HIV service priorities throughout 2017 and to seek and incorporate additional input. To help support this, CDPH extended all 2017 HIV prevention, care, and housing contracts through 2018 to provide additional time for gathering and incorporating input. In 2017, CDPH developed what we call our HIV services portfolio that was based on CAHISC guidance and all the community input that we'd received to date. The portfolio at that time included 5 components. The first, community development. Second, housing. Third, marketing. Fourth, population-centered health homes. And fifth, services for persons who use drugs. In 2017, CAHISC also conducted multiple community forums focused on portfolio components to gather and incorporate additional input from service providers as well as members of priority populations. CDPH conducted 5 focus groups with priority populations to inform our work around community development. We also conducted numerous in-person meetings with current delegates and subrecipients, provider groups, coalitions, and others to discuss the portfolio. Also in 2017, Health HIV, a national capacity building assistance provider, convened the Chicago HIV Institute, collaborations to enhance comprehensive HIV prevention, care, and treatment support. We did this to help prepare HIV partners for changes that were coming to the HIV services system. We also conducted a capacity building needs assessment with current delegates and subrecipients to identify areas for additional capacity building assistance support. On the prevention side, we were able to provide infrastructure development funding to HIV prevention delegates to help them prepare for upcoming changes. And at the end of 2017, CAHISC examined health home models from other jurisdictions. So in 2018, CDPH is finalizing the HIV services portfolio, again, after 20 months of community input and CAHISC guidance. So here are some of the key takeaways that we learned from the engagements throughout 2016 and 17. The first, Ryan White services lead to positive health outcomes. However, too few people living with HIV are enrolled in Ryan White, right about 50%. And for persons vulnerable to infection, no similar systems exist. So we must increase access to both clinical and supportive services for more people. And those benefits must be extended to persons who are vulnerable to HIV infection. Second, housing opportunities for persons with AIDS and housing services also lead to positive health outcomes. However, too few people living with and vulnerable to HIV have access to supportive housing services. So we must increase access to housing for more people, and again, those benefits must be extended to persons who are vulnerable to HIV. We also heard that often individuals are on their own to navigate complicated systems of healthcare, supportive services, and housing, particularly if they do not receive Ryan White and or HOPWA services. So the takeaway is that we must better coordinate delivery of comprehensive services to increase the likelihood that people living with and vulnerable to HIV have every opportunity to benefit from these services. We also heard that individuals are complex and face many life circumstances that lead to poor health outcomes, including HIV infection. So we must invest resources to address root causes of health disparity, including systemic racism. Resources must be invested in communities most impacted by HIV and must create opportunities and power in communities that are marginalized by prevailing systems. We heard a lot of input, feedback, and concern around smaller organizations. And the key takeaway is that smaller organizations are essential to reaching and serving marginalized populations. So future funding opportunities must embrace the value that smaller organizations contribute. We also heard and recognized that Chicago has a long history of successfully implementing HIV services. So future funding opportunities must strive to preserve what is working, even as it moves to accelerate progress toward getting to zero. And finally, people living with HIV who are virally suppressed cannot transmit HIV to their sexual partners. So Chicago has chosen and will continue to embrace undetectable equals untransmittable, or U equals U, which means service providers must follow current science when they're working with HIV-positive patients. So the final HIV services portfolio includes community development, housing, healthcare access, which is a new category, expanded beyond, but it also includes population-centered health homes, marketing, services for persons who use drugs, HIV testing in healthcare settings, which has been added, resource coordination, which has been added, and evaluation and quality management. In the following slides, we will walk through in detail each of these funding categories across the HIV services portfolio components. Within the slides, we use the term anticipated funding opportunity or opportunities. This refers to the number of requests for proposals or other funding mechanisms for each service portfolio component. I want to be clear that this term does not refer to the number of anticipated awards for each funding opportunity. So we'll start with community development. The purpose of community development is to address the intersections of HIV and social determinants of health. For example, employment, housing, and social exclusion and isolation. We're anticipating 5 separate funding opportunities for this component. Funds will support the development and implementation of 4 initiatives, 1 each focused on Black, gay, bisexual, and other MSM, Latino, gay, bisexual, and other MSM, cisgender, Black, heterosexual women, and transgender persons. An additional funding opportunity will support comprehensive evaluation of these 4 initiatives. Funded projects must include partnerships between communities, community organizations and/or coalitions, and evaluators. Partnerships will assess root causes of HIV disparities caused by social determinants, seek solutions from community members to address these root causes, develop systems-level interventions to reduce disparities at a population level, implement interventions, evaluate interventions, and then, importantly, disseminate the intervention and evaluation findings. The next component, healthcare access. The purpose is to support comprehensive, coordinated clinical and supportive services that promote the use of antiretroviral medications for HIV PrEP and HIV treatment. We're anticipating 9 separate funding opportunities for the healthcare access component. And again, many opportunities will result in multiple funding awards, but there will be 9 separate funding opportunities. The first opportunity focuses on population-centered health homes. Funds will provide comprehensive clinical and essential support services for both people living with and vulnerable to HIV to promote antiretroviral use for HIV PrEP and HIV treatment. Population-centered health homes can be implemented through partnership or by standalone organizations. Population-centered health homes will be required to provide services in each of the following categories: outreach and recruitment, HIV testing, linkage to healthcare, engagement and retention in healthcare, primary care and or HIV-related medical care, medication adherence, STI screening and treatment, mental health services, substance use disorder services, and direct provision of or referral to employment assistance, nutrition services, vision services, oral health care, specialty medical care, and hormone therapy. The second funding opportunity within healthcare access is population-centered health homes for persons living with HIV who have complex medical and or behavioral needs. Funds will provide all services referenced under population-centered health homes and services to enhance engagement of individuals living with HIV who are chronically disconnected from care and or who have chronically high HIV viral loads. The next opportunity under the healthcare access component is highly targeted HIV testing and linkage to care. Funds will provide highly targeted HIV testing and linkage to HIV treatment via population-centered health homes or other healthcare providers for newly diagnosed persons, linkage to HIV PrEP via population-centered health homes or other healthcare providers for vulnerable HIV-negative persons, and re-engagement in HIV care and treatment via population-centered health homes or other healthcare providers for persons previously diagnosed with HIV.
Just a quick reminder, if you could please type in your questions in the chat box. We may have some time at the end to open the phone lines, but for now, if you could please type in your questions. Thank you.
The next funding opportunity under the healthcare access component is essential supportive services. Funds will provide non-clinical essential support services for persons living with and vulnerable to HIV. Services will support successful antiretroviral use by connecting individuals to HIV PrEP or HIV treatment via population-centered health homes or other healthcare providers. Essential supportive services can be implemented through partnership or by standalone organizations. Essential supportive services will be required to provide services in each of the following categories: outreach and recruitment, HIV testing, linkage to healthcare, engagement and retention in healthcare, and direct provision of or referral to other needed supportive services, including STI screening and treatment, mental health services, substance use disorder services, and employment assistance. The next funding opportunity in the healthcare access component is HIV primary care. Funds will provide primary care and or HIV-related medical care, medication adherence, and STI screening and treatment for persons living with and vulnerable to HIV. Services will support antiretrovirals by providing direct HIV PrEP medical care and HIV medical care and treatment. The remaining funding opportunities under the healthcare access component include legal services. Funds will provide legal services for persons living with and vulnerable to HIV to support successful ARV use for HIV PrEP and HIV treatment. Food bank. Funds will provide food to persons living with and vulnerable to HIV in support of successful ARV use for PrEP and treatment. Financial assistance. Funds will provide financial support, including emergency financial, health insurance premium support, emergency housing, and transportation for persons living with and vulnerable to HIV to support successful use of ARVs. And finally, medical case management. Funds will provide system-wide coordination of medical case management services for persons living with HIV. Services will support successful ARV use by connecting individuals to HIV treatment via population-centered health homes or other healthcare providers and supporting medication adherence. There is a question in the chat asking to define vulnerable to HIV. Vulnerable to HIV includes populations that see the greatest number of new HIV diagnoses in our jurisdiction. At this point, those groups include gay and bisexual men of all races and ethnicities, cisgender heterosexual black women, and transgender persons. All right, so moving on to the next component in the portfolio, housing. The purpose is to provide housing for persons living with and vulnerable to HIV. We're anticipating 2 funding opportunities under this component. The first, housing for persons living with HIV. Funds will provide housing for persons living with HIV to support successful antiretroviral use for HIV treatment. The second, housing for persons vulnerable to HIV. Funds will provide housing for persons vulnerable to HIV infection to support successful ARV use for HIV PrEP. Yes, we have a question, and I'll take questions as I can through the presentation. Some of them we'll have to take at the end to make sure that we're able to answer thoroughly. Will more housing resources, including emergency housing, become available? Right now, resources are pretty limited. At this point, we have not allocated specific resources to any of these funding opportunities, so unfortunately it's premature to be able to answer that question. Another question, will the case management cover hepatitis C positive individuals? Case management does cover duly infected HIV and hepatitis C individuals. So if a person is living with both HIV and hepatitis C, then yes, medical case management can support those individuals. The next component is marketing, and the purpose is to develop and deploy cohesive and consistent HIV and sexually transmitted infection health marketing campaigns. We're anticipating 1 funding opportunity, and funds will support the development of brand and identity for cohesive and consistent HIV, STI, and health marketing campaigns. Funds will support deployment of 1 to 2 branded campaigns annually, at least one of which will promote the use of antiretrovirals for HIV treatment and or HIV PrEP. The next component, services for persons who use drugs. The purpose of this component is to provide health and harm reduction services to persons who use drugs, and we're anticipating 1 funding opportunity. Funds will support the delivery of health and harm reduction services for persons who use drugs, including but not limited to needle and syringe exchange, HIV and hepatitis C testing and to care, overdose prevention, and direct provision of or referral to primary medical care and other substance use disorder services. The next category, component, evaluation and quality management. The purpose is to ensure that CDPH-funded HIV services are implemented in a manner that leads to achievement of goals and provision of high-quality services. We're anticipating 2 funding opportunities under this component, and funds will support evaluation and QM of CDPH-funded HIV services. The next component, HIV testing in healthcare settings. The purpose is to implement routine opt-out screening, and we anticipate opportunities. Funds will provide routine opt-out screening in healthcare institutions. And the final component in the portfolio, resource coordination. The purpose is to link persons living with and vulnerable to HIV to needed HIV services. Anticipated funding opportunities is 1, and funds will create a comprehensive resource center that provides information about and direct linkage to HIV services for people living with and vulnerable to HIV. And for folks that are submitting questions, my team is recording them, and we will go through those as soon as the formal presentation is over. So know that we do see your questions coming in, and we want to address those, and we'll do that as soon as the formal presentation is complete. So some final comments. The first is that we recognize that many of our current services lead to positive outcomes. We preserve these services in the funding opportunities that we just shared. But despite our success, we know that current efforts alone are not sufficient to get to zero in the next 10 years. So we must expand access to healthcare services and services that support healthcare for more people living with and vulnerable to HIV. Where beneficial, HIV prevention funds have been integrated with HIV care and housing funds in the funding opportunities I just shared to expand access to persons vulnerable to HIV. As an example, legal services. We note that those services will be available to both people living with and people vulnerable to HIV. Historically, those services were only available to Ryan White eligible people living with HIV. We've identified resources on the prevention side to expand legal services as well as many other services to those vulnerable as well as those living with. We also want to let you know that smaller organizations have a primary place in the funding opportunities. That should have been apparent in the conversation that I've just shared, healthcare access in particular, as well as community development. There are definite places and primary places for smaller organizations. We continue to work with the Illinois Department of Public Health HIV/AIDS section to explore opportunities to implement comprehensive programs throughout the Chicago eligible metropolitan area. This is a question that we've heard numerous times, and please know that we're continuing to work with our colleagues at IDPH to explore opportunities for comprehensive programming across the EMA. Another concern that we heard throughout the engagements that we held was the inclusion of trans persons. So know that transgender persons are explicitly included in the funding opportunities. Medical case management, housing, legal, and financial will be funded at the systems level rather than individual organization levels. So there was questions as to whether medical case management would be broken up and spread about the population-centered health homes, and the answer is no. We will be funding medical case management, housing, legal, and financial at the systems level for systems level coordination rather than at the individual organization level. We also received a lot of questions about employment support, and know that employment support is explicitly referenced in the funding opportunities. Evaluation and quality management will be funded to support the implementation of HIV services. We received a lot of questions about how we will evaluate the effectiveness of this new model or components of the new model. Know that up front we're building in evaluation and quality management so that the services that are provided are as high quality as possible. We also significantly expanded services funded under the healthcare access component. This means there will not be a wholesale reboot of the entire HIV services system, and we will ensure that effective services are preserved while making room to accelerate progress through new ways of organizing services. This means that we can test and demonstrate the impact of new approaches to delivering services through the portfolio, along with the services that we have historically provided. Population-centered health homes will be implemented as part of the larger healthcare access umbrella. The underlying premise of population-centered health homes isn't new or unique. It really is built on the success we've seen in Ryan White programs, or comprehensive coordinated services. Many organizations are already using this model, or I would add, would choose to if barriers were reduced. Population-centered health homes have real tangible benefits. The first, they extend benefits to non-Ryan White eligible persons living with HIV and persons vulnerable to HIV infection. They incorporate the desire for and value of whole person approaches to health care. They prioritize comprehensive approaches to healthcare engagement instead of siloed approaches which can create barriers for customers. Additional benefits include allowance for partnerships and innovative models of care, minimizing upfront bureaucratic barriers. For example, asking partners to develop siloed program plans and budgets that on the back end, programs and partners have to stitch together after contracts are awarded. Health homes allow partners to plan for their entire system on the front end, and then we'll worry about contracts on the back. And population-centered health homes also promote patient choice and flexibility in combination with other health care access and resource center funding opportunities. So here is the timeline that we're able to share at this point. We released the week of January 15th an initial communication that described the broader funding categories, the HIV services portfolio components, and timeline. Just yesterday afternoon, we released to partners a more detailed communication of the information that we've presented to you today. We're holding this webinar right now to walk through the funding opportunities and timeline. And over the course of February and March, the Community Health Services team will conduct direct outreach and engagement of all current delegates and subrecipients to discuss anticipated funding opportunities and the timeline, as well as institutions and organizations that are not currently funded by CDPH to also share with them opportunities and timeline. As soon as we're able to share the release dates for funding opportunities, we will do that. We are still in the process of developing that calendar. So I'm going to pause. We have quite a few questions that have come in. All right, so we've done a quick scan of questions that we've received, and one that has come through multiple times asks about system level versus individual level in the way of the projects and initiatives that we're looking to fund. The easy way to think about it, system level interventions are meant to address the needs of a population. So we're looking for population-level health outcomes when we think of systems-level interventions. Systems-level interventions aren't specifically focused on the delivery of service to individuals, but rather through structural changes, removing barriers that impact an entire population. An example would be working to increase trans-inclusive health care by increasing the number of healthcare providers that are able to provide that healthcare. So individuals ultimately benefit, but the intervention itself is getting healthcare providers on board, trained, and able to provide that care successfully and appropriately. Individual is focused on the individual level, and much of what we're funding in the portfolio focuses on individual level. Services like the delivery of medical care, the delivery of medical case management. When we refer to systems level for medical case management, legal, financial areas, that simply means that we'll be funding a single organization to do systems coordination. So working with our entire HIV services system to implement legal, to implement medical case management and the like. Another question had to do with how do we define smaller organizations? We actually do not define smaller organizations. We heard from multiple partners over the last 25 months, many of whom were, as they defined, smaller organizations, asking us if this model and the work that we would be funding would make room for organizations that weren't clinical care providers, that didn't have multiple locations, and the answer to that is yes. So we don't have a strict definition for what a smaller organization is. I think the takeaway should be that within this portfolio, there's room for all of the organizations that CDPH currently partners with our current funding, and that is the key takeaway.
Definitely. There was a question if ADAP is going to be still available in the jurisdiction. ADAP is a category that is funded under the Part B program that the Illinois Department of Public Health is responsible for, and yes, it will still be available to the Part A jurisdiction.
The last two questions on the list, so can agencies funded for services subcontract with other organizations? Depending on the category in the proposal, yes. Most of the categories will clarify if that's not something that you could put in your proposal. There will not be a gap in funding between this current year and the 2019 funding opportunity, to respond to Andrew's question.
We had a question about will organizations who are not currently funded by CDPH be eligible to apply, or will it make a difference if organizations aren't currently funded? No, that will not make a difference at all. This will be, as we have historically, a release of an RFP open to any organization that's eligible, and eligibility will not include previous funding from CDPH. Tamika asks us to introduce ourselves. So I am Dave Kern. I've done most of the talking. Jorge Sestu stepped in and answered the question about ADAP, and Ayla Kara Mustafa answered the question about gap in services. So be patient with us as we look to your questions.
I feel comfortable taking a stab at one. So this is Patrick Stonehouse in response to the question about combined budget within the health department, and effectively as how are we going to be providing more services and integration for the same or less money and also serve more people. It's a very important question, and one that we've spent a lot of time addressing internally, as well as sort of gathering information from folks externally. And the manner in which we're going to do it is largely by looking at potential overlap of the funding opportunities we have. So for example, how can CDC funding for HIV prevention, which has a mandated amount that goes towards prevention with individuals who are living with HIV, and be used to leverage or offset certain things for Ryan White. So sort of in that manner, looking at the manner in which these funds that we currently receive can support one another. So basically allowing for the different funding streams to go towards what they're to be allowed to provide support for one another. At the same time, looking for some of the programs, or looking at some of the programs and activity that we've been doing or that we've been funding for our community partners to do that haven't been showing effectiveness based on the evaluations that we've done, the outcome data that we've gathered, or were never even intended to address the goals that we have put in place, which are viral suppression for individuals living with HIV and PrEP adherence for individuals who are highly vulnerable to HIV. So those programs and services that we've been supporting that aren't even trying to address those goals are not going to be going to receive continued funding from us. So through those two activities, as well as continuing to support agencies to figure out ways of billing for those activities that they are able to bill for, and building up infrastructure to be able to access third-party billing systems, all of those things coming together, as well as looking at other opportunities for bringing funding in, is how we're going to provide the resources to expand the services involved.
Right, and I will add, this is Dave Kern again. We had a question about how can revenue that's generated through healthcare, understanding that healthcare institutions are able to generate revenue outside of governmental public health funding, how can some of those funds be redirected to help serve underserved communities and work with organizations that don't benefit from that kind of revenue generation? I will say that that is one area where we do believe we can find some savings as compared to the current system that we use. So thinking about, just as an example, the provision of outpatient ambulatory care, and knowing that a vast majority of individuals that we serve are insured, is there a different way that we could look at investments in outpatient ambulatory that might make some of those resources available for other things that we historically have not been able to provide? That's just an example going along with Patrick's example of some of the other inefficiencies or just changes in direction that we've had through the development of this portfolio. We have a question, can you address what is meant for systems level funding for housing? That simply means that housing as a service will not be integrated into the population-centered health homes under healthcare access. We will have a separate funding mechanism that funds housing for persons living with HIV and a separate funding mechanism that will fund housing for persons vulnerable to HIV. Having said that, there is a requirement, or will be a requirement, that the providers under healthcare access will be required to work with our housing provider systems. That will look like a direct referral to housing for individuals that pass through population-centered health homes or essential supportive services providers or highly targeted HIV testing providers. We're wanting to put the network together so that individuals that those providers come in contact with who can benefit from housing have a way into learning more about the opportunities for housing that exist. Additionally, the resource center that we talked about is meant to be a center where individuals and providers within our system can contact to get questions answered about what's available and, if at all possible, to do direct referrals into services like housing. We have a question, just to be clear, will legal organizations funded by CDPH be able to serve vulnerable populations vulnerable to HIV? And so let me clarify. We have been able to identify some HIV prevention resources to integrate into service categories like legal so that organizations funded under that particular service category will be able to provide legal services to both Ryan White eligible individuals as well as individuals who are HIV negative or HIV positive and not eligible for Ryan White. So we're able to expand the number of individuals that can receive that beneficial service, knowing that it has worked very well and is essential to the health and wellness of the folks who are part of the Ryan White system. We have a question about, is the presentation being recorded and can it be accessed by others? Yes, it can.
Yes.
It is and it can. So we're scanning through questions.
So this is Patrick Stonehouse again. There was a question asking about clarification between drug user health versus, or services for people who use drugs versus services for people who inject drugs. And the purpose of that was really to allow for a fuller use of resources by those agencies and organizations that are working with individuals who use substances either through injection or other routes of administration. Previously, funding that had been specifically focused on individuals who inject drugs were fairly restricting in what services those agencies were allowed to do under that specific funding category and criteria. So what we're basically allowing them to do when we expand it in this way is to address the needs of those individuals who are already accessing their services but maybe just aren't injecting drugs. Overdose deaths are not solely related to the injection of opioids, and so really wanting these agencies and activities to be able to fully represent and respond to the needs that they're seeing. So it's purely an expansion, not an elimination of injection services, but allowing them to address other needs that are involved.
Great. So a few other questions that we're seeing. The first, clarifying under the health care access component, distinctions between primary care as a standalone category and population-centered health homes. So we heard loudly and clearly from partners over the last couple of years that the concept of population-centered health homes, which provide, as you saw, many, many services within a partnership or within a single organization for the folks that we're serving, had real benefit, but that there was a need for services outside of those comprehensive systems. So what we've done under healthcare access is taken some of the component parts within the health homes, for example, HIV testing and linkage, essential supportive services, and the direct provision of primary care, and we'll be funding those alongside health homes as standalone categories. So for primary care, the requirement or eligibility for that would look like an organization or an applicant would just provide the primary care service. They wouldn't have to provide all of the other essential supportive services that are required within the health home. The same holds true for essential supportive services providers. That category is meant for organizations that do not provide direct clinical care and or may have relationships with multiple clinical care providers, but what they're really good at is providing those essential supportive services. And the same holds true for HIV testing and linkage. So in addition to the health homes, the healthcare access component has been expanded based on the input that we received to include standalone HIV testing and linkage, standalone essential support, and standalone primary care. We had a clarifying question on hepatitis C co-infection and the availability of medical case management, and the answer is at this point, yes. An individual would have to be co-infected with HIV and hepatitis C, or HIV, in order to receive support for their hepatitis C infection through medical case management. We had a question about the two funding opportunities under evaluation and quality management. Simply, we will be, at this point, anticipating releasing one funding opportunity that will focus on evaluation of HIV services that we're funding, and a second funding opportunity that will fund quality management of those services. So at this point, we're envisioning one funding opportunity for each.
So this is Patrick again, just seeing a couple of questions we can respond to. Will the services for persons who use drugs be separate from substance use outpatient services? The answer is yes. Substance use outpatient services is involved in the population-centered health home model. The services for persons who use drugs is separated from that. This is a standalone funding opportunity for separate services, although those services, the intention behind the services for persons who use drugs is that they would then be able to refer individuals over to population-centered health homes. But back to the original question, yes, these are separate funding streams. What agency will be making the decisions on who gets the awards? That would be the Chicago Department of Public Health. Let's see.
This is Isla. Rev Green, you asked a couple questions about not currently funded agencies. We'll be engaging, and this opportunity will be open for both currently funded agencies and those that are not. And during the months of February and March, we'll be working closely with those that are funded and doing outreach to those that are not to basically spread information about the opportunities.
So we just got a question about, this is Patrick again. Will there be a ceiling for the budgets? If so, what is it? There more than likely will be a ceiling, but we're not at a point where we can, we haven't made those decisions yet. So that information will be coming out probably along with the RFPs when those are released.
There was a question about psychosocial support and if that is included. The answer is yes, within the engagement and retention and care, as an example. Psychosocial support certainly could be a service category that organizations choose to include. So yes, it is there. There was a question about successful ARV use. How are we defining successful ARV use? In the context of getting to zero and the focus on use of ARVs for PrEP and viral suppression, successful ARV use would be maintaining being prescribed and maintaining and adhering to ARVs to the point of viral suppression or to the point at which there's sufficient medication in the blood to prevent acquisition of HIV. Let's see, we're looking at additional questions.
I believe there was a question earlier, this is Isla again, about legal organizations. Will they be funded to serve non-positive clients? And I believe the answer to that is no.
They've answered it already, and it is.
Great, double answer.
Okay.
I'd like to take a stab at one of them that I see on there. The question of with the creation of evaluation as a category, will funded agencies be reporting to whatever agency gets that contract instead of CDPH? And the answer is no. Agencies will be involved and will be required to work with evaluators in terms of exchanging data, manualizing activities, looking at different ways of implementing or adaptations that may be necessary once an organization gets started in implementing their services, but they won't be reporting to them. CDPH will work with the agencies as well as the evaluator to make sure that the distinctions between the responsibilities of the evaluator and the health department are clear. CDPH is the funding agency. The evaluator is purely looking at the implementation and outcomes of the activities that are being provided. But the health department is the entity to whom agencies will be reporting.
Yes, a few other questions. Are we looking at multi-year awards? The answer is yes. We certainly are not looking to do one-year contracts for the portfolio. We're looking for multi-year awards. How many years has not been determined yet. We had a question about, is there a ballpark as to when RFPs might be released or funding opportunities? I would say, given the number of distinct funding opportunities that we will be releasing over the course of this year, I think it is very fair to say that they will be released incrementally. So we won't release all of them at once. We'll begin releasing them as they are completed, vetted, and approved through the city system. And once we have that calendared, again, we will let you know. We understand clearly that releasing RFPs toward the end of the year before new contracts start can be really challenging. So we are trying to be very, very mindful of that. We had a question about funding start dates. Our CDC HIV prevention resources and corporate resources have a January 1 start date. Our Ryan White resources have a March 1 start date. We are still having conversations about when funds will start. So that will be made available as soon as that decision is made. There was a question about, will psychosocial services still be available or fundable? And the answer is yes, in the context of the population-centered health homes, the population-centered health homes for behaviorally and medically complex individuals, and within essential supportive services, absolutely. Applicants can include psychosocial support if that is what they're choosing to do within the program they're defining. Let's see.
There's a question from Kenya that says, will the new funding formula limit Ryan White services to only certain segments of the population as opposed to the current structure, which is open to all people? It will absolutely not limit the funding to any particular part of the population we serve right now. It will be open to all HIV positive individuals that need access to care of last resort.
Mm-hmm. We have a question about, if RFPs are being released incrementally, how can organizations plan for what they'd like to apply for? Will there be a list? What we just presented and what we sent out yesterday afternoon, looking at the components and the funding opportunities under those components, that is your list. So what we just presented, that's the list of RFPs that will be released. I'm sorry, funding opportunities that will be released. And I make that distinction because there are a few other options we have outside of the RFP process that for certain funding categories might make more sense. We're exploring that now. That's why we're using funding opportunity instead of RFP. Is promotion of PrEP mandatory to all at-risk demographics? The promotion, one of the two primary goals of getting to Zero Illinois is increasing the use of PrEP by 20 percentage points. So yes, we would expect, where appropriate, that promotion of ARV use for HIV PrEP will be one of the outcomes that we're looking at for the funding that we're putting out. In some categories, it may look a little different. Thinking about community development, in particular, those projects are very much meant to work with communities to define the needs that they have, and work with communities to define the solutions that they believe will work for them. And all of that is in service to supporting PrEP and ARV use for treatment, but those projects might look a little bit different. We have a question about, will CDPH fund a campaign regarding undetectable equals untransmittable, getting to zero, and PrEP? The marketing component that we described is intended to create a uniform brand and identity for our jurisdiction under which campaigns can launch over time. So meaning that we'll have a brand and identity, and we're hoping that we'll be able to launch 1 to 2 campaigns every year through this funding cycle. And those campaigns very likely will focus on things like U equals U, PrEP, and getting to zero.
Just because we're getting to a point, there was a question earlier about to whom should you send future questions. I feel like from our perspective, any of us. You can direct questions to us. Also keep in mind that we are going to be going basically on a tour of all of our existing delegate agencies and subrecipients where we can go over this information more, either in person or over the phone. Thank you. And then for any other organizations that are interested in gathering more information, you're also welcome, Reverend Green, you in particular. As I noted that you mentioned this in one of your questions, feel free to reach out to us and we will do what we can to schedule either a call or a webinar or an in-person meeting so that we can discuss those things. So the contact information I believe was provided at the beginning of this.
Yeah, what I can do is I will forward to everyone who registered a copy of the slide sets. Is that okay?
Yeah.
A PDF copy of the slide sets, a link of the recording, and also any other materials they may want to share, in addition to all their names and contact information. So I'll put that all together in a nice package for everyone, and I'll email that out as soon as I get everything together. Perfect.
We had one question about the number of funding opportunities. At this point, and again, this is what we're anticipating. We don't anticipate significant changes, but we can never guarantee that. We're looking between 20 to 22 separate funding opportunities. And I will say that, I know that sounds daunting. It sounds daunting to us as well. Some of you know that the city recently implemented a new e-procurement system through which all RFPs must be run. And that system allows us to only create RFPs for specific and single categories. So we're not able to do, as we have in the past, bundle multiple categories in one RFP and then on the back end separate those out and score them independently. Right now we have to, each particular funded category or funded project has to go through separately. We are right at 12 o'clock.
Oh, yeah, and so I guess we're done.
So I want to thank everyone for participating on this webinar. I know that you may not have been able to see, but there were well over 220 individuals on this webinar this morning. Certainly demonstrates interest, and I'm hoping that we at CDPH have been able to clarify some of the concerns that you had, answer the questions that you've raised, and that we did demonstrate that we have heard the input that you provided, we valued that input, and wherever possible we incorporated it into this funding services portfolio. So thank you all very much. The slides will be sent out. As Patrick mentioned, the team will be contacting currently funded subrecipients and delegates to have conversations about what was presented. For organizations that aren't currently funded that want to have conversations, please reach out to us, and we would be more than happy to talk.
And again, thank you. And if you can please complete a very brief, quick survey. If you click on the link, it says right there, really brief post-program survey. I would really appreciate that. And again, I will be emailing out to everyone who registered all the information. Thank you.
The leader has disconnected. The conference will be terminated in 5 minutes.